Perfect. With a theme of knowledge sharing, I think we really saw, if I just go by the chatter in the room, some probably amazing sharing, whether that's knowledge or personal stories, but that connection has been fantastic even on that short break. Before we jump into our first keynote of the day, I think we enticed you a little bit with this idea of door prizes, and so we didn't want to make you wait any longer. We do have an amazing door prize for one of the Quanlin Dunn books that has recently come out, so super exciting. I will hold this box for Shayna. Make sure she's not cheating.
No. Okay, if you have the ticket number 5235869, you are the winner of this book. Last three numbers, 869. Listen, I do the organizing behind stage. Hey!
I'll pass your box back. Thank you. Yeah.
All right.
Come on up here.
Come on down. This is like the Price is Right. Come on down. Perfect. Congratulations. All right. And as we said, there will be door prizes for the hubs. Those will happen at the end of the day. So make sure you stick around and those will be in place. So without further ado, I think we are really excited to be able to announce our first keynote presentation for the day. And I think for many of us here in the territory, but really across the country, this is a topic that is either very near and dear to our hearts or very near and dear to our communities. And I think when we think about the current opioid crisis, the losses that we're facing and the issues that are coming forward, I think this is something that all of us are probably holding quite closely. So we do have Skye Barbic and Roxanne Turuba, who will be talking about community-based solutions to the opioid crisis. They'll be centering the voices of youth, caregivers, and communities as experts in their own care. And so we'll have some conversation led by them. Just a quick bio on both of them before I hand it over to them. And so we do have Roxanne, who will join us here in person. And so Roxanne is a research coordinator at Foundry, which is based in Vancouver, BC. She completed her Master of Public Health at Lakehead University while assisting research that aimed to improve access to maternal care and substance use services in rural and remote communities. Currently, her work focuses on understanding and improving care experiences of youth who use substances, particularly in participatory research methods. She is passionate about studies that empower people to be active partners in the research process to improve their service experiences and outcomes. She will be joined, as we can see on screen here, by Skye Barbic, who is an associate professor at the University of British Columbia in the Faculty of Medicine. She's the head of science at Foundry, an integrated youth service in British Columbia that provides free and confidential health and social services to youth between the ages of 12 and 24. She's passionate about health services research, measurement-based care, and patient engagement. And so without further ado, I will ask you to come on up and we can listen to the important work you've been doing.
Quick sound check. Can I say good morning? Roxanne, you can hear me? Thumbs up.
Yes, we can hear you. There we go.
Good. All right. Good morning, everyone. Thank you so much for having us this morning. And our last 24 hours has been a bit of a roller coaster, and we were quickly moved into this keynote spot this morning. And so we've changed our workshop a little bit to our keynote, and just really grateful to have us in this opening plenary session. And we take this with a lot of humility and gratitude because this is a really important topic to us. I'm just also really grateful. I'm sorry I can't be there in person, and thank you for letting me present virtually. I just have I'm living my best life in the sandwich generation right now, taking care of some older parents that really need us close by. So thank you for letting me present virtually. I'll pass it over to Roxanne to do our land acknowledgement.
Okay, Thanks, Skye. So just wanted to start by thanking the Wisebor folks to invite us on the lands of the Tan Quechan and Council and the Kwalendun First Nations, not only to speak about our work, but also to learn from members of the community and other folks from across the country who are going to be speaking today and tomorrow. And so we'd like to just also acknowledge that the work that we're going to be speaking about today took place on the stolen lands of many strong Indigenous nations on what we now call British Columbia, and that the work that we're presenting represents many project team members, community partners, organizations and community members who took part in this project. It's really their collective efforts that made this project possible, and so we are honored to kind of present on their behalf. Okay, so I just wanted to start by kind of introducing myself. So my name is Roxanne Turuba, and I'm coming from Vancouver, but I'm originally from Northern Ontario, from a small town called Hearst, which is on the stolen lands of the Anishinaabe people, which really comprises a large part of Northern Ontario. And I know on the map, it doesn't actually look like it's very north, just given how vast Ontario is, but we do get pretty cold and snowy winters. And my hometown's about 5,000 people, and the closest city is Thunder Bay, which is a 5.5-hour drive. And on the other side is Sudbury, which is a 6.5-hour drive. So I myself grew up with quite limited access to healthcare. And I was also diagnosed with a chronic health condition in my mid-20s. And so I experienced a lot of challenges with the healthcare system. And part of my healing journey was really talking to other people who are going through similar experiences and just really learning to find my own voice and advocating for myself. And so that's one of the reasons I am really passionate about empowering people to be active members in the research and really empowering people to find their own voice and making sure that their voices are being heard. So that's just a little bit about me, and I will pass it on to Skye to introduce herself a little bit more.
So this is sort of our failed attempt to say that we identify with the North, but we don't. They called us Southerners when we were getting ready for this talk, and I thought that was saying, I said, no, I really live in the North. But when we started to actually look at where we live, we definitely grew up in rural and remote towns, both Roxanne and I. So I lived up in a town called Mont-Laurier. It's a small ski town. This was a ski hill that a bunch of dads cut some trees down, and this is where we spent a lot of our time and a lot of our days as young people. If you weren't a skier, you were often finding other ways to engage in meaningful activity, and that often was related to using substances, and there was not a lot of other things to do if you weren't a skier in our town. And so substances were everywhere. They were easy to get. Often was alcohol, cannabis, acid started becoming popular in this time, but we grew up and people didn't die in my town. They didn't die of overdose. It was very rare, but it was very common for folks to use substances. And there's a large journey. Montreal was my closest town, 2 hours away, 4 hours in traffic to get to Montreal if you needed services or any specialty services. And we had a lovely journey of moving across the country with my family and I, and we ended up in Vancouver. And this is a picture of, they told me when I moved to Vancouver, there'd be no snow. It was warm and it was wonderful, but every single winter, this is what Vancouver looks like. And so I'm glad we moved our shovels out here. But really, this is our attempt to say that we do. I think Roxanne and I bring a perspective of the community first, and what does the community actually need, and small communities and communities that are not directly connected to large city centers often need a different perspective. And so this is some work that we've done in the last couple of years. We're pretty excited to share with you today. Next slide. So this is our content for today. And this is a cartoon. It's one of my favorite cartoons because sometimes when we talk about patient-oriented research, this is like one of the things that we do. We just try to measure it really quickly. And this is a cartoon that says, the way I feel is really hard to quantify. It's hard to describe how I feel. And someone will say, well, how hard is it? Like 1 to 10. Put yourself on a scale of 1 to 10. And when we're talking about substance use and we're talking about outcomes associated with substance use, you know, the number one outcome we talk about is death, but it has significant impact on other types of outcomes, quality of life, function, the overall well-being of a community, the level of hope, empowerment communities have, and these things are really hard to measure and they're hard to capture. And when you have public health initiatives to address issues like substance use problems and the overdose crisis or drug toxicity crisis, we'll define that in a second. These are things that you just can't put on a stats board and talk about. You really need the perspective of the patient and their families and the communities in which they live in. So we're going to walk through, I'm going to give you the sort of current state of what is happening currently in our West Coast of Yukon and British Columbia. I'm going to discuss some population approaches to date, and my moving to British Columbia just happened to be right at the start of the drug toxicity crisis, and so sharing some lessons about what this has been like and what the type of research, but also the clinical services and the population approaches to trying to treat the problem. And then Roxanne's going to shift over and talk about next steps and application and really shift to the power of community and what the power of community can be in looking at how to contribute to solutions to this problem. And then we're going to end with some calls to action. And hopefully these calls to action can support some conversations at the conference and some dialogue about how we can move forward in a good way. Next slide. So I'm just going to start with the takeaway message. And this is, if you want to go leave after this, this is the takeaway message. But, you know, Roxanne and I truly, truly believe that if you're going to create an impactful substance use response or policy, it requires an aligned approach with communities at the center. And if communities are at the center, you're going to have effective outreach with rapid uptake of evidence that considers the community's diverse needs and strengths. If you do it in a mediocre way, it's going to take time. It's often going to be ineffective. And if you do it poorly, it's wasteful, unethical, and dangerous. Next slide. So before I get into some of these statistics, this is really to anchor myself because we've been doing this work for nearly a decade and in this space, and we sometimes forget, you know, just how hard the work is, and we forget with how many people have been impacted. And not that we forget, it's just that I'll show you the numbers shortly about how significant this is impacting all of our communities in British Columbia. And so when you're doing the work every day, it's just really important to start by grounding ourselves that this is impacting everybody, and everyone that we know of has been impacted this in some way, shape, or form. So we do acknowledge with heavy hearts the thousands of lives that have been lost due to the drug toxicity crisis in British Columbia, Yukon, and the rest of Turtle Island. And the work we do is really in their honor and hopes that lives can be saved. Next slide. So we share a lot in terms of reflecting and coming into this talk. So we do share the obvious of our geography of being on the western part of Canada, Turtle Island. We share culture, and we have deep, rich history of Indigenous culture that have been here for thousands of years and really set the path for us to live on these lands in a good way. We have history, and the impact of colonization on the West Coast certainly impacts both of our jurisdictions in a significant way. We share lots of natural resources. We share the Yukon River. We share economic ties as a result. And unfortunately, something else that we share is the drug toxicity crisis. And so we use the term drug toxicity crisis because there's actually quite a lot that has, you can go to the next slide, Rox. When I started off and really in 2014, 15, started to talk about a fentanyl crisis, that one of the first visits I ever made to a young person's apartment who was accessing our services, he was making synthetic fentanyl in his bathtub. And I remember just looking at the psychiatrist and asking the young person who I was with, like, walk me through this. What do you mean you're making fentanyl? And yeah, he was making a homemade fentanyl, something that he found off of YouTube, that he was teaching himself how to do this with the hope that he would be able to sell this as OxyContin on the streets, and or sell it to local drug dealers, and that there was this demand for this thing called fentanyl all of a sudden. That was a faster hit. And so the fentanyl crisis was used, and then the term opioid crisis was used to really sort of starting to embrace a large group of types of opioids, both synthetic and non-synthetic, that were on the drug market. And then really what has moved, especially in British Columbia, is towards the concept of the drug toxicity crisis, that people are dying because the drug supply is toxic, that people are dying because they're not sure what they have anymore, what they're getting in what they're purchasing is whether it's clean or not clean, and this is why people are dying. And so the term that we will use for the rest of the presentation is the drug toxicity crisis. So current state, sorry, back Roxanne, one more slide. So really current state in Yukon is that you declared this substance use emergency related to opioid deaths in January 2022. This was a significant call by public health officials, because there was a really significant increase in opioid related deaths. And this was a commitment from the government to respond in a meaningful way, to acknowledge that this was happening, and to provide the resources to address and meet the needs of the communities who were being impacted. Next slide. And so this is one of the things that British Columbia, it's really been interesting actually, because British Columbia is now 2,771 days into their public health emergency related to the drug toxicity crisis. And so in our drug toxicity crisis was declared in 2016 in April. And we've had this line that you can see at the bottom was really the start of what we were seeing as overdose deaths in British Columbia, and really starting to peak in that 2014, 2015 area. And that's the same time that I met that young person who was building his synthetic fentanyl lab in his bathroom in downtown Vancouver. And so this was not coincidental. There's a lot of new knowledge about fentanyl, and a lot of new knowledge about how to get it into the drug supply. And so this escalated BC's response to the overdose emergency. And there was lots that was done. And so really from a public health perspective, there were many things that were done, including opening up the first safe supply organization, where you could go in and access safe supply, and then also use in an environment where you're supervised by nurses, that there was no stigma, that people didn't ask you questions. You went in, and no one has ever died at an overdose drug prevention site in British Columbia. And so this has been absolutely like an important public health issue. We have had attempts to decriminalize simple possession of substance use in British Columbia. There's been overdose task forces everywhere. There's been attempts to develop strategic plans that focus on prevention and treatment and intervention, and increasing resources to various places to understand where the problems are and how they can be supported, and really responding to the crisis part of it all, like trying to respond to prevent death, and to respond to support folks who were in crisis. Next slide. One of the big investments in British Columbia has been the investment in the coroner's office to have these dashboards really readily available to public community members and to communities to look at the trends happening over the years. And so the top left bar graph is that trend really, where you see 2014 to 2015, you start to see that increase starting. It goes up very significantly in 2018. I can tell you that the morale of a lot of our health providers was really, really low. 2018 was the year I committed to stop going to funerals, because I was going to, on average, 14 to 20 funerals a year for young people, and also friends and people I knew. And so it wasn't just impacting folks who were marginalized or racialized, or struggling, for example, in the downtown east side. This was impacting everybody in our province. And in 2019, we started to see the number go down for the first time. And this was a really big beacon of hope for starting to look at some of these public health interventions, like overdose prevention sites and like early prevention sites that we were starting to put into place. And then, of course, 2020 happened. COVID hit, and this was absolutely a population and a public health initiative that was trumped and masked over by COVID, and you can see the numbers just go skyrocketing. In 2023 in British Columbia, we are on pace to have the highest overdose numbers that we've ever had. And so there is really no predictability of it in terms of anything except for it's going up. And so the months, so there's one time in April it's the lowest, and another next April it's the highest. And so there's a lot of variation, really impacted by what's in the drug supply at the time. Next slide, please. This is just another. It's a really interesting tool if you look at how they've set up the coroner's website using a tool called Power BI. But you can really actually look at anything from gender to age to the type of community. For example, really perceive that the most overdose deaths was happening in the large community areas like Vancouver and Victoria. That's true this year, but last year it was actually much smaller communities such as Hope, Chilliwack, and Prince George. And so these are really important statistics to understand where things are happening so that public health interventions can be targeted. This is one specifically of age, and I just want to highlight, you can go to the next slide, Roxanne, that primarily what we were thinking of is this is impacting folks who are 25 to 45. That was primarily men who were passing away from overdose. But what we ended up learning really quickly was that this was now all of a sudden the leading cause of death among BC youth age 18 or 10 to 18. And some of you in the room are saying 10-year-olds, that's impossible. We actually had 2 10-year-olds die of overdose last year. And so this is traumatic. It's traumatic to communities. It's traumatic to families, obviously. It's traumatic to the young people who are around this group. And really what we heard overwhelmingly is Roxanne working with young people and others working with young people is, well, what do we do about it? There's nothing. What is there for young people to understand the problem? How do we actually understand their perspective? And every time we sort of got momentum, we also just were reminded that another crisis or public health issue was always in the way. So it wasn't just COVID. All of a sudden this summer, for example, our province was on fire, and your territory was on fire, and other territories were on fire. And it was just, this was our major focus this summer was keeping people safe, and people who had moved from different communities and were transient across communities. And so it just seemed to be this one public health crisis on top of another. And climate crises and social justice, and how do you actually look at this really complicated problem and try to address these issues in the best way possible. Next slide. So one of the solutions tends to really quickly be, well, we should get more money to solve the problem. And so this has been a solution in British Columbia. In 2017, or I think it's 17 or 16, it's going to be one of those two, but we had our first Minister of Mental Health and Addictions, Judy Darcy, who was appointed to really develop a strategy to address both mental health and substance use concerns in our province. This is the first time in our Ministry of Health that we ever had a dedicated group of folks who are focusing on this. And at the end of the day, we also had this federal government who's really interested, but health is a provincial and a territorial jurisdiction. And so there was only this limited feeling of what the federal government could do other than transfer funds to the provinces. And then the provinces really being responsible for allocating the resources in the way that they thought was best. And so primarily in British Columbia, we've allocated resources from a public health perspective in ways that are trying to respond to the escalating drug poisoning crisis. So just some examples of what has happened in British Columbia. We've had new beds for addictions and recovery care. There's been a lot of focus of the funding on decriminalization and access to safer supply. There's been development of lots of apps. That, like I would say we're closer to 100 at least apps, different types of apps. But there's a really good app called the Lifeguard app that's been developed, but you have to have access to a phone. But there's over 127,000 users who have registered for that app. There has been really big initiatives in places like pharmacies where you can get take-home naloxone kits. There's drug checking services that are primarily in larger city centers, community responses, lots and lots and lots of teams that are being developed, called community action teams that tend to be primarily focused in larger city centers. And so the really like top-down approaches, like bigger services, and assuming that these services, if they're there, if you build it, they will come. And so what we've seen, next slide, Rox, is that this has sort of been this typical approach, is that there's a problem, we need more money to fix the problem. And now we're really, you know, in 2023, almost 2024 in British Columbia, our numbers are going up, and the question is, why is the problem not fixed? What's going on? Why are we not addressing this problem? Next slide. So really what Roxanne and my team have been thinking a lot about, we're not going to fix the complexity of the drug supply, but really what the voice that's missing, and that's been missing in the entire process, has been shifting the power to community. So there's been larger organizations, federal, provincial organizations, that have been really responsible for co-designing the solutions and implementing the solutions that they think are going to address the problem. And absolutely, like, I want to be clear that these interventions are meeting a large need. And I think British Columbia would be in a way more severe place if it wasn't for some of these public health initiatives. However, I think we could be in a much better place if we center the needs of community. And so next slide, Rex, I think this one's you. And yeah, sorry, just one last thing before I pass it to Roxanne. There's no need for any more research about what needs to happen, but the definite gap in the research is the voices of folks from community are totally missing. And so Roxanne and my team and I have been working really closely at trying to work with diverse types of communities and folks to really understand what the solutions are from their perspective, and how do we actually work to shift power to the community so that communities can feel empowered to answer the questions that their own community members have, respond when there is a crisis, but also be really equipped from a prevention and health promotion perspective. So I'll pass it over to Roxanne to really talk about how we're shifting a little bit to thinking about the power of community, and how do we put the communities at the center of the work that we do.
Thanks, Skye. So yeah, I'm going to share an example of a community-driven project that we conducted at Foundry called the Improving Treatment Together Project. Also, I'll refer it to as ITT project. And the main goal of the project was really to improve the experiences and outcomes of youth ages 15 to 24 who are accessing opioid use services. And we did this by co-designing solutions with youth, as well as their caregivers and service providers who provide opioid use services. And this was a multi-phased project, which started in 2018. And we finally wrapped it up this year. So it's been a very long time coming. So this project involved numerous partnerships, including national, provincial, and community partners. So the Canadian Centre on Substance Use and Addiction, also known as CCSA, is a national organization that provides leadership on addressing substance use-related harm. And so they got a pot of money and approached Foundry with a project that combined community-based participatory research and co-design methods to really identify and develop solutions for improving opioid use services for youth. So just a little bit about Foundry. It's a network of integrated youth services that provide mental health care, substance use services, physical health, physical and sexual health, peer support, and social services for youth ages 12 to 24. And we have centers across the province who provide all of these services in one location for convenience. And we also provide virtual services. And so we partnered with 4 community-based Foundry centers, and we tried to choose diverse communities that were spread across the 4 regional health authorities in BC, and also had high rates of opioid-related toxicity events at the time of the study. So we also had our ITT project team, which was really integral in facilitating the research and the project activities, including building relationships with community partners and our community members. So our ITT project team involved researchers from CCSA and Foundry, And then in each partnering community, we hired youth with lived and living experience of opioid use to be part of our project team and make sure that young people's voices were embedded into the project throughout each phase. And then we also hired a community champion in each community to support with phases 2 and 3 of the project, which I'll talk about a little bit later. And then the project team recruited young people, caregivers, and service providers from each community to participate in the co-design of the project in different phases. Okay, so in phase 1, we held 9 community workshops, which were stakeholder specific with our 4 communities. So we conducted workshops with youth, with caregivers, and with service providers. And the first part of the workshop really involved understanding people's experiences when accessing or providing opioid use services. And we did this by doing empathy mapping exercises and journey mapping. And then we asked participants to identify specific needs that were associated with these experiences. And so I'll just briefly share kind of the main experience that were expressed by these 3 groups of folks. Okay, sorry. So for young people, they really described difficulties finding and staying connected to opioid use services, and specifically highlighted challenges finding safe and inclusive services that were youth-friendly. So a lot of services were adult-oriented, and youth also described feeling judged when accessing services. Yeah. Okay. Meanwhile, caregivers described often having to become their young person's case manager, so having to navigate the system for their caregivers and facing multiple barriers when doing so, just not knowing where to go, and having to really be those system navigators. They also described enduring a never-ending roller coaster trying to keep their young person safe and alive, and feeling a lot of judgment, self-blame, and isolation. And then service providers also described a lack of youth-friendly service options, which made it really challenging to meet youth's complex needs. They also described organizational silos and a lack of time, which really hindered their ability to build trusting relationships with youth and really respond to their needs. So you can see already that there's a lot of overlap between the barriers that young people, caregivers, and service providers share. And service providers also specifically highlighted how system-level policies that informed their organizational practices often hindered their ability to meet the needs of youth. And so they really underscored the need for a more coordinated response between policymakers, communities, and individuals. Oh, sorry. So then the second half of the workshop involved getting participants to kind of pick the needs that they were most passionate about addressing, and then brainstorm solutions to address those needs. And then those solutions became low fidelity prototypes as they described more in detail what that solution would entail, how it would be designed, who would be involved, and how it would be implemented. And so this led to 31 prototype ideas to improve youth opioid use services. And these ranged from education programs, interdisciplinary care teams, resources to improve system navigation, support for caregivers, creating youth-friendly spaces, and new programs to improve young people's access to services, housing, financial support, and meaningful connection. So you can see that the solutions weren't just specific to youth opioid use services, but really like the broader range of care that young people need who are accessing opioid use services. So in phase 2, we kind of went through each of the prototypes to really determine whether we could develop the idea within our project timelines and budget, and whether the prototype could be sustained beyond the life of our project. So unfortunately, with project funding and limited time, it would be difficult to develop and sustain a entirely new program or model of care. But hoping that some of these ideas can be picked up by policymakers down the line and be implemented. So for our project, we really refined the list of prototypes and developed a condensed list, which we brought back to our community partners to discuss. And we really talked about, what prototypes were kind of matched their organizations and what resources they had in their community to kind of support the development of that prototype, how novel the idea was, whether we could do it in our project timeframe, and then also the potential impact that the resource could have. And so this, after brainstorming with our community partners, we chose 3 prototypes to develop with our communities. And then this is also the time when we hire community champions to really support with that co-development of the resources and also support with the local implementation. And so the next slides, I'll just share 2 prototypes that we developed. So the first is a parent handbook, which was developed with our community partners in Victoria. And this was in response to the community's need for more tools to help caregivers support youth who use opioids and other substances. And so this handbook's aim to provide caregivers with relevant information about substance use disorders, and how to navigate the healthcare system in relevant situations. And they also wanted to provide emotional support through storytelling. So the community champion in Victoria was a family peer support worker who had their own experience of parenting a young person with an opioid use disorder, and they were really well connected with caregivers in the community, which really supported with recruitment of caregivers to participate in the co-design process. And so we engaged with 12 caregivers with lived and living experience who met regularly to develop the content for the handbook. And during the first meeting, caregivers really shared their vision for the handbook and really highlighted the importance of personal stories to help other caregivers feel less alone in their journeys, and really underscored that recovery isn't linear and it looks different for everyone, just to help reduce stigma and shame. And so the caregivers brainstormed potential topics and then kind of prioritized which topics were most important to include. And then we separated into breakout rooms to develop that content with 3 to 4 caregivers per group. And that was facilitated by our project team and really who took notes while caregivers conversed. And we used prompt questions to help kind of guide the conversation. So for example, asking caregivers what their journey or experience was like, what were some of the barriers, what did help, and what do they wish they had known. And we also audio recorded the meetings to really, so that we could go back and listen and make sure that the content was included in caregivers' own words, because we really wanted it to be kind of like a support group in a book, and the caregivers like speaking to other caregivers. And so caregivers were given opportunities to write their own sections and include stories. And then we also consulted with service providers and other content experts just to develop subject-specific content. And then caregivers were also involved in informing the format, design, and illustrations of the handbook. And we did this in collaboration with a graphic designer who had experience with working with community-led projects. So it was really important that we worked with vendors who kind of understood that our community partners had to be involved in the decision-making, and that the project timelines were subject to change just given the iterative nature of co-design, and also just like wanting to really make sure that caregivers were happy with the final product, and so just to be amenable to that. So this is a quote from a caregiver from the working group about their experience with the project. So I've laughed and cried with you, and I am excited that, you know, if I look back to full blown where we were and where I am today, and the fact that we can all collaborate and put our bits of information in here and get it into the homes of other parents who are paralyzed and lost looking up the hill in front of them, I'm very grateful. So this quote is just to demonstrate how this process could also be therapeutic for caregivers, and that it was kind of a support group in itself. So this led to an 8-chapter handbook, which is available freely on our Foundry website, or if you use the QR code. But there's also hard copies on the tables if folks want to bring them home. Please feel free to keep for yourself, or if you know a caregiver who might benefit. And there's other copies at the front if folks want more copies. So just go request them if needed. Oh, sorry. Okay, so even though the handbook was created by caregivers in Victoria, it is still very transferable to other communities and very relevant to other caregivers, regardless of what community they're from, because it does include a lot of personal stories. And so we've come up with ideas on how to use the handbook in practice. And so one way is to really integrate it into clinical practice for service providers to kind of have conversations with caregivers about youth substance use. and also help them connect with appropriate services and support groups. So even though the resources in the handbook are mostly specific to Victoria, caregivers can come back to their service providers and be like, hey, I read about this resource in the handbook. Like, do we have anything like this in our community? So just to kind of start that communication. Family peer support workers can also use the handbook in this way. So our community champion in Victoria is actually doing book club sessions. So kind of each week they're given a chapter to read, and then they come back and debrief on it during their support groups. And then we've also given Foundry Centers and services in Victoria copies, hard copies, to kind of keep in the waiting room so that caregivers can pick it up and read while they wait for the appointment. And then we also encourage communities to adapt the handbook to their local context and also include their own local resources. So CCSA actually developed an adaptation toolkit, which is freely available at the link or the QR code. And they developed this since a group from Sault Ste. Marie approached us and wanted to adapt the handbook for their communities and include their own stories and resources. And so, yeah, because we do acknowledge that, you know, the experiences that caregivers share in the handbook might not reflect everyone's experiences. So we did try to really avoid giving concrete advice, but more just sharing diverse perspectives. Okay, so the second prototype we chose to develop was a virtual opioid agonist treatment guide, or OAT guide. And OAT is an evidence-based treatment for opioid use disorder. And although it's been proven to be safe and effective for both youth and adults, youth are much less likely to access it for a number of reasons. So they might experience dissuasion from family members or service providers who might not be as educated about OAT and might be hesitant to prescribe OAT to youth. They may have also been denied the full range of OAT options. So young people have shared that they're often pushed to take Suboxone, which is a partial opioid agonist, rather than full opioid agonists such as methadone. And there might be different reasons why young people want to go on methadone rather than Suboxone. And youth might also perceive that OAT as a long-term commitment because that's usually how it's used in adult populations. But often young people don't want to be on OAT very long. They just want to go on it to kind of kickstart their recovery, and while they kind of get other supports in place to kind of promote that recovery and then get off it. So their treatment goals sometimes don't match what they're being offered. For that reason, we created this virtual guide to help educate youth and service providers about OAT, and we created it from a young person's perspective to really help improve youth and service provider relationships. And we took a more collaborative approach. So we worked with 2 community partners, which allowed youth from suburban settings like Kelowna and more urban setting like Vancouver to share their experiences with OAT. So for this, we hired 2 youth peer support workers and a mental health clinicians to be our community champions. And so they were also very important in recruiting participants who were actively receiving OAT. And we took a bit of a different approach for this one because recruitment was a bit of a challenge, just given that we were doing this during COVID. So we, instead of having a concrete working group, we did initial rounds of interviews with youth to identify key themes in the format of the guide, and then we kind of refined them with second rounds of interviews. And then after these interviews, we kind of built a more formal working group with 4 youth who had lived experience of OAT. And we developed podcast-style video series where a host would interview a young person about their OAT journey. And so youth shared what a typical day looks like for them, as well as the benefits and the negative aspects of OAT. And then a nurse practitioner was also interviewed to kind of describe what OAT is, where you can access it, and why it's important. And those interviews were audio recorded and used to complement the videos. And the graphics for the videos were also developed with a young person with lived experience. So just to share another quote from a working group participant about the experience. So I feel very fortunate to have been involved in this project from the beginning and to see how it has evolved. It is a great learning opportunity and inside look at how resources/educational tools are created from inception to finished product with youth health at the forefront. So this led to 4 unique episodes on youth accessing OAT, which are freely available on the Foundry YouTube channel. And so we can play the first kind of 5 minutes of the video just to show you what it entails.
The moment I realized, oh, this is gonna help me.
My luck had kind of run out.
We're not just junkies, we're human beings.
Deserving of a life without chaos.
Connect with others so you can get that community.
If I can help save any lives, that's what I'm here to do.
Hey, I'm Sam. Welcome to our podcast. Today's episode is You're Worth It. And I have my collaborator, Sasha, here.
Hi, I'm Sasha. I met Sam through peer counseling at the youth clinic. And when he told me about this podcast, I offered to help illustrate it. Getting back into art has been part of my recovery journey.
The people you are about to hear from are real, telling it like it is for them. Youth like me who are on an OAT journey. OAT, opioid agonist treatment, sometimes also called therapy. Genesis in Kelowna, and Alice, Jay, Kitty, and Randy in Vancouver. Plus, nurse practitioner April coming to us from Nanaimo. Some of them have changed their names to protect their identities, so let's hear it from them.
So I was working the carnival across Canada, joined the carnival so I could have a roof over my head. We were driving through Vancouver and I was like, well, just drop me off here.
I was used to living in a life of addiction and chaos, and that's what I was comfortable with.
Things were getting pretty bad. I was kind of in harm's way, living in the street, trying to find a different way.
Being an addict doesn't mean you're a bad person. You are who you are, and you can recover.
And I'm deserving of recovery and a life without addiction.
And we are worth saving, and we're not just junkies, we're human beings, and we have the right to have a treatment for our medical issue.
If I didn't get on OAT, I know that I would be mentally, physically, spiritually, and emotionally just drained. I might not even be here. Drugs nowadays are crazy strong.
The drug supply is very, very toxic. So when you're buying something, there's really no way to tell exactly what you're getting. It's been over 5 years since BC's provincial health officer declared a public health emergency.
Thanks. Okay. So encourage you guys to go check out the rest of the videos, which are, there we go. So again, even though the guide was created by youth in Kelowna and Vancouver, it's all very transferable information. And so how we've kind of envisioned this guide be used is, again, as a way for service providers to have conversations with youth about opioid use treatment options, and that this information is presented to young people from other young people so that it's more relatable, and also gives them ideas of the types of questions they should ask that they might not have thought about. And so in the first video, they did talk about some side effects that might happen, and so just considerations that they may not have considered asking before they start their OAT. And so this also includes peer support workers, so who are supporting youth who use opioids and may not be seeing a substance use specialist, and they might not have information about this otherwise. And then again, the guide can be kind of played in the waiting rooms for youth and caregivers to watch while they wait. So just to finish off, I just wanted to share kind of how important our community partnerships were for the success of the project. So first off, they really played a big role in organizing the phase 1 workshops, which were in the community. So thankfully this happened right before COVID, and we were able to go to the communities to do the workshops in person. They really supported with recruitment on the ground. And we also had peer support workers from each Foundry Center at the event to kind of make sure that we had, to help create safe spaces, and also have the opportunity for folks to kind of take a break if things got too heavy and have someone they could go talk to if needed. And then having strong community partnerships also enabled us to identify a strong community champion who was also integral for the co-design process. So they were well connected with community members and really helped us recruit co-design participants and select appropriate engagement methods, especially during COVID, which was very challenging. And their role as a peer support worker, again, enabled us to kind of help create safe spaces for youth and caregivers to share their stories and also just mitigate the power dynamics between the project team and the participants. So they were facilitating the workshops, the working group meetings with us. And so just to help mitigate, because sometimes there's a lot of power dynamics between researchers and participants, and having youth team members also helped with that. So just want to thank all our project partners and our project team members. It involved a lot of people and a lot of years, so just thankful for them. It wouldn't have been possible without them. Okay, so we had originally planned a brief kind of workshop activity, but just given that we're a much larger group, and just for feasibility, I'd probably just go through the activity together. But just kind of wanted to get folks thinking about kind of the first few steps of co-design and really thinking about like the who and the how in your own community. And so the first step would really be identify the needs of your community. And so I chose just an example to kind of help ground the activity, but a need that came from youth, caregivers, and service providers was really this need for improved system navigation and just a greater awareness of resources. All right, so the first step is just identifying the needs of your community. So how would you go about identifying whether this is also a need in your community? Who would you need to be at the table? And encourage folks to include their thoughts in the chat, or if folks want to share. And I can also just give you guys some kind of considerations that we thought about for our project. So I'll just give you guys kind of a minute to think about it.
In general, maybe we'll wait till after this activity and then we'll have questions.
Sure.
You have some ideas?
Hi. No, it's not on.
Hello.
There you go.
Okay. Shrewsbury Ashley Russell, Trondhekwichin DJ, Dawson City DJ, Whitehorse Huchin, Trondhekwichin Government Elder Support Worker, Tradadahokai. My name is Ashley Russell. I'm a member of the Trondhekwichin from Dawson City, but I live in Whitehorse, and I work for the Trondhekwichin government as Elder Support Worker. Outside of my work, I'm involved in a lot of Indigenous health and wellness programs and projects, and one of the things that I've been contracted to work on is the Indigenous Harm Reduction Program. And so we do a lot of interviews with Indigenous people, specifically youth, that would like to share their stories about how they lived harmful lives. Mm-hmm. And one of the things that I see and hear over and over is that we need a safe space in the Yukon for youth to address the people in their lives that enable them. The amount of youth that have come to me and said that if it wasn't for their aunties or their grandmas saying, well, it's better to drink with us than drink down the street, they feel like, well, there's no point in me even trying because just everyone around me is supporting it. So we need to host the safe space for youth to confront the people in their lives and sit down and have that face-to-face and say that this is happening and it needs to stop. This summer, I lost my younger sister to fentanyl overdose, and she left behind 4 babies. 3 of them were under the age of 4. So it's affected me personally as well. And I know that we need just more safe spaces for those conversations to happen. Masi.
For sure. Thank you so much for sharing. And I'm so sorry for the loss of your sister. Yeah, definitely having safe spaces to have those difficult conversations. So bringing folks together So that can involve not just young people, but members of their family, maybe caregivers, elders, service providers, other folks to kind of make sure those safe spaces. So we really leaned on peer support workers to be there to kind of, if conversations went a little bit awry, is like to bring it back to the purpose of the conversation, and the purpose of the project and what we were trying to achieve with that. So I'll just share some other ideas. So maybe there's already community level data available. So maybe you've already talked to community members about this issue. And so making sure we're not overburdening communities and asking them this, sometimes we hear from young people, we're asked to retell our stories over and over and over again. And so making sure we're not doing that. And if we've already asked them those questions, identifying that and working from that instead of reinventing the wheel every time. And then also considering equity deserving populations. So folks might have more difficulties accessing, navigating the system, and also might have a harder time even engaging in these types of activities. And so making sure we're making efforts to reach those populations and making sure that their voices are also heard. Okay. We're good. The second step, so we only have 5 minutes, so I'll just go through this a bit quicker, and then I'll leave questions at the end. And if folks want to kind of provide more input on this activity, please feel free. So the second step is really to identify a lead organization that could lead this work in your community, get buy-in and dedicated resources. So if you think about your community, what organization could lead this work? Who should be on your project team, and also thinking about how you will compensate participants. So just from learnings from our project, identifying an organization who's connected to community members in the community that you're trying to engage with makes it a lot easier and helps kind of build that trust already, since it's people that already have connections with people in the community. For the project team, really important to identify individuals who are passionate about the work and can help build strong relationships with the community, since that's going to be their main role, is to really get folks involved. And also involving youth on the project team, we found was important to make sure that their voices are being heard, and that it's not just the researchers leading that work. And participants should be well compensated for their time and effort. So it's a lot to ask people to kind of share their experiences. And so making sure that that expertise is valued and that their time is also valued. So for our project, people were often coming after work to work on this. And so making sure that they're also getting paid for that. The third option is to identify community champions. So who in your community could be well equipped to support with the local development and implementation. So again, a community champion that's well connected to the community and can help foster that connection and that safety. And also just making sure that the co-design process is actually being led by the voices of communities. So really making sure that they're involved in the decision-making, rather than having the research or the project team making those final decisions for them. And then finally, this would be the step where you recruit and partner with people in your community. So who should you engage in the co-design process? How can you recruit participants? So again, recruiting and partnering with existing community groups and organizations that are already connected to young people. And also just making conscious effort to reflect the diversity of your community in your engagement efforts, and make sure that everyone's voices are being heard. Okay, so I'll pass it back on to Skye to talk about calls to action very quickly.
Okay, I need 1.5 minutes, if that's okay, the conference organizers. But these are really important. So just want to end with a couple of calls to action. Next slide, please. So the number one takeaway is putting the community at the center. And this is clear, and Roxanne just demonstrated that when we're talking about complex issues. Thank you to the participant who shared your story. This is not an easy issue. This is extremely complex and requires communities to be empowered to come together and hear these stories and have the solutions be co-designed in ways that may be about developing policies and actions, but also maybe ways about sharing stories and having talking circles and having arts-based methods for sharing story, having safe spaces created for young people, for elders, for different folks of all ages and groups to come in and be able to get the care that they need where and when needed. Next slide. The second thing is really there's an opportunity for us to work as a learning health system. And so we have lots of learnings in British Columbia, but we're sure that there's lots of learnings in Yukon, and we're really grateful to learn from folks over the next few days and bring these learnings home. And really, there is no incentive from the way that our health system is structured for our provinces and territories to work together, because health is really a provincial and territorial jurisdiction. But this is a complex problem that was all requiring social determinants of health, understanding history, understanding complex issues relating to the drug toxicity crisis, and the impact it's going to have for many years to come. And so what we have is this opportunity to work as a learning health system and to collaborate and understand learnings that are happening in communities and share those in a good way, in a meaningful way, but in a timely fashion, so that we could have these types of conversations on a regular basis and share our learning. Next step. This is just a really important one that you'll see organizations will start to fund a lot of data systems and capturing data, but the data has to be in the hands of the community. It has to be in the hands of people who can make decisions about what to do with the data, how to interpret the data. And the data governance is so important to think about when you're thinking about data collection strategies at a territorial or provincial level, and how does that actually get in the hands of the people who are going to make the decisions, the family members, the young people, the schools, the police, whoever is going to be involved in making decisions or responding. So you're not always responding to the crisis and the data that comes in, you're getting prepared and responding to the needs of the communities, the diverse needs, in a developmentally, culturally sensitive way. So data matters, but data in the hands of the right people matters the most. Next slide. And just on our concluding last two slides, that we do share a lot. And I do hope that we share a really community-centered approach to dealing with the drug toxicity crisis, that we prioritize new ways of doing things that puts communities at the center. And just to finalize our last takeaway message again, that if you're going to create an impactful substance use response policy approach of any kind, it requires an aligned approach with our communities at the center. And I truly think we're going to do it well on the west coast of Turtle Island, and we're going to have effective outreach that's developmentally, culturally appropriate with rapid uptake of evidence. But it's complicated, and if we don't put communities at the center right away, we're going to have a long, miserable path ahead. But if we do it together and we put our communities at the center and we empower them with the resources they need, we really, really can get ahead of this problem. So thank you for having us. Extreme gratitude. And Roxanne will be here to answer all the hard questions over the next 2 days, but feel free to please reach out. Thank you to the folks too at the satellite centers. If there's anything that you want to share, or stories or solutions, we're really invite an open conversation, because we really want to learn from you, and we want to solve this problem. Thank you.
Thank you so much to both of you. I believe we do have about 10 minutes left in their time where there are some questions that I think the audience definitely has. So we can take questions here off of the floor on site at KDCC. And then we do have the team set up to be able to nab any questions out of the chat. So if there's anyone with questions, just put your hand up and we'll bring you a mic.
Hi, my name is Maluk Galbraith. I'm from Iqaluit. My family is from Turuba. I am a recovering opiate addict. From 15 to 29, I suffered with addiction. And when I was 29, I finally went to rehab, but the rehab center that I went to is run by people that were addicts, recovering addicts. So I was wondering if you have a team of recovering addicts that can relate to these kids and relate to this youth, a part of your team. Is that something that you guys have?
Yeah, so we partnered from Kelowna, Victoria, Prince George, and Vancouver. We actually had young people who had lived or living experience of opioid use. So some of them were still actively using, some of them were in recovery, so different kind of journeys. But those folks had actual lived experience. And then as well as like during phase 2, when we actually developed the resources, we engaged with folks who had active like lived and living experience of opioid use. So definitely wanted to make sure that their voices were like embedded into the project, and that the presentation, or like, so for the opioid guide, for example, making sure that it was like coming from them and not from service providers, to make sure that the information was relevant. And you know, they know best what young people want to know, because they've actually experienced it. So yeah.
We've also had a lot of our young people who participate who have become peer support workers, or they've gone on to from being a youth research assistant to then going on and doing their master's in social work. We have a young person who was in one of the videos who's now leading a big opioid response team in Toronto, and has moved to Toronto to lead that, and is really the expert leading a large group now. So really interesting how that opportunity to share their lived and living experience as part of the project it's been not just extremely valuable, but they also mentor younger people who are coming into our program. They mentor their families, but now they're moving on to career opportunities where they're leading in places clinically or public health. And so it's really, and in research, we've got one young person in that project who's now doing their PhD. So it's very cool. But we can't do it without the voices of people with lived and living experience, and everything that we do, youth and families are at the center of the work.
Yeah, a lot of success stories, and yeah, I think like that's the thing, is like, you know, you engage with young people and give them these opportunities to kind of use their lived experience to help others, and then they feel empowered to kind of keep doing that, and it's led to like working as a peer support worker to support other people who are going through experiences. So it's awesome to kind of see that growth and that journey.
Thank you. Any other questions?
Oh, hi. My name is Lauren White. I work for Health and Social Services in engagement of people with lived experience. I was just wondering if you could expand a little bit on the types of supports that you offer to the youth and their families and their caregivers as they're going through the engagement. Like, I know you had mentioned that there are some support workers at the focus groups or the interviews, which is great, but is there any supports that are offered before or after the engagement ends? So
yeah, for sure. So maybe I'll speak a little bit about phase 2, because I actually started the project at phase 2. And so we had quite a few like safety kind of like procedures just to kind of make sure people felt safe. So for example, like our first meetings with people, we were like, okay, what do we need to feel safe in these meetings? And we actually developed like a community agreement that we go through it before each meeting. So just like, you know, being respectful of others, like, you know, maybe there's certain topics that people might feel triggered about. And so just like giving kind of a trigger warning or those kinds of things. And so if folks kind of strayed away from our community agreement, we could go back to it throughout the meeting. We also really gave folks the opportunity to kind of engage in the way that they wanted to and were able. So for example, there was a meeting with the caregivers, which was on overdose. And one of the caregivers, you know, had their daughter had gone through an overdose and passed away. And so, you know, just letting her know in advance that we were going to talk about that. And so, you know, if it's too much, like, you don't have to come to the meeting. If you want to come to the meeting and then, you know, leave early, that's fine. And then so she ended up coming and then left. And so our peer support worker actually connected with her afterwards just to kind of talk and make sure that she was okay. And we also encouraged, you know, everyone to kind of connect with us. So if they left the meeting, just to let us know that they were okay. And then we checked in with them after the meetings just to make sure that they could have that support, especially because it was virtual. It was a little bit harder than in person when you're like kind of worried if they log off and you're like, okay, like, so you do want to check in with them. And then also like people sharing their stories, we really went back after and like removed any identifiable information that like wasn't necessary, because we do still want to protect the identities of folks sharing their experiences. If you know, one caregiver actually like talked about her experience openly in the news because that's what she wanted to do, but not everybody wants that and don't want to be identified. So it was just a lot of things to consider when working with people with lived experience.
I think just another thing to add is that we just being really clear about like what the level of engagement is in terms of, you know, engagement is not engaged or not engaged. There's different levels, and so one of the projects that Roxanne, or both projects actually, you said were family led and youth led, and so how do we support them and being able to be resourced to do the work, but often doing the work also in an embedded program like Foundry, where we have access to primary care, psychiatry, psychology, social work, peer support, really in real time has been greatly appreciated by a lot of our participants. So it's often in a space that they do feel comfortable to go to the first participant's comment. So it's in a space that they do feel welcome and comfortable, and they recognize and that they know also that there are available resources in real time or the next day if they want to access that, including virtual care, which has been really helpful as well. So it's sometimes you do research really, you know, isolated and you don't have access to these resources, and we're very grateful to do that. And I think increasingly, not just increasingly, it's becoming the norm now. When we are in community, we often do the work with a young person co-leading with us and an elder, and so making sure that elders are in spaces as well, and that we explain to everybody what the level of engagement is. And so if it's a youth-led project, for example, what is my role as a researcher to support the youth leading the work? Roxanne's role? What is the elder's role? How do we move forward? And this is all relatively new learning for us too. So we're trying to write this down and do a lot of reflection as we move forward. But certainly doing research in isolation is not the way we do things, and not the way we'll ever do things, because it's not safe for anyone.
Thank you again to both of you for the amazing presentation and the amazing work that you're doing. I think, as we can tell from the questions and the engagement, that this is really important for folks. And so thank you for sharing today. I'm sure if other questions arise, as Skye pointed out, Roxanne will be here for the next 2 days. And so definitely pull her aside and ask her anything that you might have.